Hello. So my name is Dr. Rob Annis. I'm a GP in Listowel, and I just want to start right away by thanking the first two speakers. I have to say that this is a great panel discussion so far. CCO for having the foresight a long time ago to engage primary care in their business, which has actually changed the way the province is working. They were the leader in that. So that's really great to see. And then the patient experience, I have to say, it just makes it so real, and the work that you guys are all doing here is so important. And it gives you that viewpoint that I think you kind of miss when you just go to another meeting, So I really appreciated that. And I think I'm within my rights to say welcome, or welcome from the Southwest LHIN. I work for the Southwest LHIN now, so they appreciate the work you do. And certainly they are looking at cancer as a chronic disease, and in their strategic plan for the next 3 years have the perfected treatment of chronic disease as one of their goals. So the Southwest LHIN is supportive of this direction. And the Southwest LHIN is also very supportive of working with primary care, and that's another one of their whole arms. And again, the health and the system's found if you have a really strong primary care system, and I'll reference this a little bit, a lot of the problems that are occurring in the system would actually disappear. And so we need to drive quality and access to primary care, which are the goals. So I was really happy to see the new draft thing, Journey, because I was about to destroy this one. No, it's this is the old one, and it still serves the purpose I want to talk about, because I'm going to just go into a little more detail there about how primary care relates to the cancer centers and treatment of people with cancer over the journey. So in the old days, before Cancer Care Ontario engaged primary care, people tended to put us at prevention and screening and maybe the start of diagnosis, and then we'd pick up again at recovery. But we weren't really, there was the black box thing where you sent them off to the cancer center, and then something happened to them, and then at some point they came back, and then a month or two later their notes came back and you realized what was going on. But actually that wasn't, even years ago, that wasn't the way it was working. And this is a study from ISIS, which looked at the number of visits to various healthcare professionals during that journey. So each of the bars are a different part of the journey. The lower bar on the left of each of these cancer diagnoses is the sort of baseline number of visits to a doctor, and yellow is GPs. So, and then you get into active treatment with cancer around just before active treatment, and then palliation. And what you see is that after the diagnosis of cancer, the number of visits to a primary caregiver actually doubles, more or less, across all cancer diagnoses. And if they're palliated, then it triples. So primary care was involved always, and a lot of that tended to be psychosocial, to be honest, when you look at the actual diagnostic codes. But primary care has been involved across the journey for a long time, and that recognition helped to drive Cancer Care Ontario's move to create these networks of primary caregivers specifically devoted to connecting with GPs around cancer treatment. And then I guess a little more specifically, and we saw some of that with the Cancer Care Ontario talk, is there's a move to really work on these two to really connect with primary care over the screening part and the recovery part. So for example, these are the number of new cases and deaths from the 3 preventable cancers. Colorectal cancer is the number 1 killer, although breast cancer kills more women than colorectal cancer. And these are, more or less preventable. So it's a bit too bad that people are still dying of these things. And if we could catch them earlier, or in the case of cervical screening, really prevent it, that would be a great thing. And so targets have been made for the 3 cancers that we screen for, and the goal is to connect to primary care to improve the capture rate of, pap smears, fecal occult blood testing, and mammograms. We want to drive those lines upward. So how do you engage primary care? So I'm going to just make the point, actually, that although we just heard that we have cancer networks, the LHIN leads are actually trying to get rid of those. And the reason is that we don't want to have 25 primary care networks in every LHIN. So you could have, we have diabetic strategy now in Ontario, and they want to network with primary caregivers, and we have a LHIN strategy in Ontario to drive some accountability in primary care, and they want to connect to primary caregivers. So right away, there are some LHINs right now with 3 primary care networks, and it just makes no sense at all. There's all sorts of issues for primary care to be connected with, and we think there should be one network. So our LHIN, the Southwest, and this was sort of the benefit in my role as the cancer lead, starting a network and then moving into the LHIN lead, is that we could make one network, and it's co-chaired by the diabetic lead and myself, the Southwest Primary Care Network. And we have a group of 10 primary caregivers, so that's 8 physicians and 2 nurse practitioners with a geographical representation of the LHIN, and each of those people are paid to connect locally to their own groups. So this is a diffusion type model, and if you think of it happening from Cancer Care Ontario or the centre sort of right out, and the other way back. So we get feedback from primary caregivers about issues in the cancer system or issues in other systems, and that they can come up, and it's a really good way a structured way of connecting all of the various programs that are out there to primary care. So my plea is, what we don't want, and what used to happen, is some program would have a new program, would change something, pap smear screening, for instance, and their approach to engaging primary care was basically CME. So they would organize lunches or whatever, and talks, and tell us how we're going to do our job now. And what we really have developed, and it's because of Cancer Care Ontario's leadership here, is a way of engaging primary care as you build these programs. So get us involved early, and then we can have the discussions about what works and what doesn't. And there's a mechanism to do that now, in the Southwest anyway. And then in the end, we think we'll have a better program. So for example, when we talked about changing the way we do breast survivorship care in the Southwest LHIN, they were able to connect with our group, the Southwest Primary Care Network, and we were able to send around the information and have a discussion about, does this work for us? How could that be done better? And just on that, we mentioned there's a lot of evidence in survivorship care. Basically, the evidence says primary caregivers and oncologists do about the same job in terms of the numbers that you measure for follow-up. And the recent guidelines that are coming out as to who should do colorectal follow-up, emerging evidence suggests that for colorectal cancer survivors who have completed all treatment, discharge from specialist-led care to community-based family physician-coordinated or institution-based nurse-coordinated care are reasonable options. So, basically no one really knows where the care is best given. I don't think there's any evidence that says one or the other is better. We do know, however, that the Cancer Centre is overworked, and primary care, the other study, is they want to do this. So 95% of physicians, when they're surveyed about doing follow-up care, want to do it. And just to put a little bit of that's my last slide here, a little bit of a warning in terms of navigation. I'm just going to speak about Mrs. Jones, who is a fairly typical patient. She's 58, and she has a history of breast cancer treated, who comes in with back pain. And as a GP, you can imagine somebody navigating this from the Cancer Centre, so organizing her mammograms, maybe doing depression screens, breast self-exams, making sure that gets done on the schedule it's supposed to get done. When we see her in primary care, here are some of the things we have to look at before we get to the back pain. And the back pain might be the cancer, right? So, part of the navigation piece is, I think that is metastatic disease. Now I need a bone scan. Is that where the navigator comes in? Or who actually is navigating this patient? So she needs her blood pressure checked once a year, her smoking history done, diet and exercise review, cholesterol done at least every 5 years if it's normal, diabetes screening every 2, bone density, PAPs, mammograms, breast exam, alcohol screening, depression screening, self-management goals, immunization update, and FOBT testing every 2 years. So these are all things that we're supposed to do on not everybody, depends on your age and stuff, on Mrs. Jones before we get there. And unfortunately, what might happen in the system is Mrs. Jones has a cancer navigator dealing with the breast cancer part, and then maybe a vascular manager dealing with the cholesterol and stuff part, and then another navigator for something else. And you end up navigating the navigators, and We don't want that. Again, a high-functioning primary care system would do all this, and it's my belief that a lot of this other navigation is going to happen because the primary care system isn't functioning where it should be. But if we drive quality and connect them to the system, I think we can get there.